I'm Doug Rex. I'm a gastroenterologist at Indiana University Hospital in Indianapolis and professor of medicine at Indiana University School of Medicine. EMR stands for Endoscopic Mucosal Resection, and it's the primary or first-line method that we use to resect polyps in the colon that have a broad attachment to the wall of the colon. They could be flat or they could be shaped sort of like half of a golf ball. But the idea is that they're sort of have a shape to them and a size to them that we use this technique called EMR as opposed to simply putting a wire around it. And all it means really is that we are going to first inject fluid underneath the polyp. So the polyp, which is a lesion that can grow and turn into cancer, so we want to remove it so it can't do that. And the polyp is in the first layer, what we call the mucosa. There's a layer underneath that we call the submucosa that's very loose and really accepts fluid. So we put some fluid under there with a needle and the polyp will lift up and separate from the muscle, which is the third layer down and the one that we want to protect from injury. And so EMR, endoscopic mucosal resection, basically is a way of lifting polyps up and then going ahead and removing them with a snare. And it's got several advantages. First of all, if we do create any injury to the deeper layers, we can see it because we put some color in there that allows us to tell the second layer from the third layer, and it gives us some safety in terms of protection. And also for some polyps, it's very helpful to delineate the edges. So EMR, it's our primary way of removing broad, flat polyps in the colorectum. The reason that EMR is the first line way to remove any polyp that hasn't yet turned into cancer as opposed to surgery, or the reason why we always want to remove it by colonoscopy as opposed to surgery is, first of all, it has much less risk. In the United States, if you look across all the literature, the risk of dying from a surgical procedure to remove a section of the colon, it's about 0.7%. It increases with age. By age 80, it gets up to around 3%. On the other hand, the risk of removing polyps through the colonoscope has incredibly low risk. It's very unusual for somebody to have a fatality from even a complication from colonoscopy. So it's got lower risk. It also has lower cost because when you have a surgical procedure, that's more expensive, but then you're going to be in the hospital typically for at least a few days. Whereas after EMR, you're going to go home. We almost always discharge people to home, so the cost is less, the risk is lower, the chance of complications is lower also. There are some lesions that we see during colonoscopy that we don't want to remove by EMR. First of all, some of them we can remove by even simpler methods, but still through the colonoscope. Some polyps are kind of like, they look like a tree with a trunk or a mushroom. They're sort of growing on a stalk. A lot of people think that's the way most polyps are, but it's actually the minority. They're pretty easy to remove by just cutting through the stalk. And a lot of them are small enough that we don't really have to raise them up on this mound of fluid. So, but for the broad flat lesions, we would like to remove them by EMR or another technique called ESD, which stands for endoscopic submucosal dissection, unless we're already sure from looking at the lesion that it's got cancer in it, in which case it's better oftentimes for the patient to go to surgery. It really depends on how deep the cancer has spread into the lesion. So if we have a really clear indication from the appearance of the lesion that it's got cancer in it, then often the best thing to do is to just take a biopsy sample and then have a surgical procedure to remove it. So EMR can't do everything, but the important thing is that it can remove almost everything that's benign, no matter how big it is, and that's going to save the costs and risks of surgery. There are several advantages to having EMR over surgery. First, the lower cost and the lower risk compared to surgery. Because when we do EMR, we often, for a very large polyp, we take it off in pieces. There's a very small chance that we won't get it all. It'll look at the end of the procedure like we have it all, and we can't tell for sure, but a very small percentage. With our current techniques, usually it's less than 5%, we'll have a little bit of the polyp come back. So usually at around 6 months or a year will want to come back, take a look, examine the scar, see if any little nubbin, any little nest of cells manage to survive and grow back as a polyp, and then take care of it while it's still really small. In terms of risk, the most common problem that we have is bleeding. And the chance of that, depending on where the polyp is located in the colon and how big it is, can range from anywhere from around 2 or 3% to as high as 10%. But we do have tools to reduce that. Sometimes, depending on the size of the defect or the wound after we've removed the polyp, we can take some little metal clamps that we call clips and close the site shut, and that will actually greatly reduce the risk of bleeding. There's a very small chance of making a hole. Typically, if we make a hole, we can actually see it during the procedure and fix it, but the patient may still have to be in the hospital overnight. In our experience at our center, that happens in 1 in every couple of hundred EMRs. And so the risk of having to be hospitalized or to have clips to close an actual perforation is extremely low. So overall, the outcomes are very good because we can avoid surgery and all the costs and risks associated with that. So the recovery for EMR is actually really fast. People generally wake up from their sedation or anesthesia and feel normal. They may have very minimal discomfort from the gas. We usually watch them in the recovery area for a little while, maybe an hour. If there's any discomfort, we might stretch it out a little bit longer. And then the great news is you get to go home. You don't have to be in the hospital, except for the rare problem that has occurred that would require monitoring in the hospital. So compared to surgery, typically when there's a resection of a section of the colon that has a polyp in it, that's going to require being in the hospital. You probably have heard before that after you have a surgical resection, you kind of have to wait around until your bowels get moving again, you're passing gas. That can sometimes be as short as a couple of days, but oftentimes it's at least a few days before things really get going again. And then there also is the chance of, after any surgical procedure, of developing a hernia that could require readmission, operation to fix the hernia. After a colon resection in the U.S., the evidence suggests that about 15% of people have to be readmitted sometime within the first year after surgery to deal with some complication from the surgical procedure. So EMR, the great news is, in an overwhelming majority of cases, get to go home the same day. I will say that around the United States, there are lots of colonoscopists, especially gastroenterologists, who are expert in endoscopic mucosal resection. If you get on the internet and do some Googling, you can almost identify somebody within your region. You may have to drive, if you live in a smaller community, you may have to drive into the city, but it'll be worth it. And so if you need some help with it, you could also ask your physician, your local physician, to help you find somebody. They probably can identify somebody at the regional medical center, but almost everywhere in the United States is within a reasonable driving distance to get endoscopic mucosal resection done. I would encourage you that if you've been diagnosed with a colon polyp that has not been shown to contain cancer, it's what we call a precancerous polyp, and you've been told that you need surgical resection for it, stop for a second, because that may not be correct. Right now in the United States, we think there are in the range of 300,000 surgical procedures performed annually to remove a polyp that hasn't turned into cancer yet. And that's kind of unfortunate because, again, the great majority of those can be removed through colonoscopy. So ask around if that happens as to whether or not there's somebody who can sort of tell you what the scoop is in your region, how you can identify somebody who can remove a lesion that hasn't turned into cancer yet, that's in your colon or rectum, without having a surgical procedure. It can help you out.